We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 135, Glaucoma Session 39. And today we have with us Dr. Vinay Nangia, and he will be speaking on Epidemiology of Glaucoma in India. And I request Harsh sir to please introduce Dr. Vinay Nangia, sir.
Thank you, Rolika, and thank you, Vinay, for being with us in the iFocus. And I will read out his biodata later, but let me tell you, he's a dear friend, and what actually intrigued me was that every time we sat on some kind of seminars or something together, I was really impressed at his ability to catch very, very strange kind of patients and be able to give his comments about those kind of things. So his mind is so sharp. I am really amazed. And the first time I went to his center, the Suraj Eye Institute, I was really amazed at the huge center that he has made up, and more than that, the preventive and social network that he has created over there. And I was really amazed, and I told him so, and he said, no, it's a teamwork. I know, but you have to have a person who can get over there and do it. So, and he has been the president of Glaucoma Society of India as well. So we are truly blessed to have him today, especially because his is one of the major studies. He trained at Shankar Nethralaya and Manchester University in Britain, and at Harvard University in Mass Eye Institute and Ear Infirmary, Boston. And the other thing is that he has been involved in many public health projects in association with Orbis International, with Rotterdam Eye Foundation, Rotary Holland, and many other foundations. He was the chief investigator for Central India Eye and Medical Study, a population-based study in association with Professor Jost Jonas from Heidelberg University in Germany. And that is the study that is always quoted whenever epidemiology in India is this thing. So I told him he's very, it was a great work done by him. He was also the chief investigator for the Central India Children's Eye Study, and he's a collaborator for the Global Burden of Disease and for the Non-Communicable Disease Risk Factor Network and Asian Eye Epidemiology Consortium. He's a South Asia member of the Vision Loss Expert Group. He has over 150 publications across international journals and more than 50 in Lancet. Absolutely amazing. So welcome, Vinay, and you are the right person to please teach our students about epidemiology. Please go ahead, sir.
Thank you. Should I share my screen?
Yeah, please.
Yes,
Okay, and we have the hot seat participants also with us.
yeah, two of them have joined, sir. I've
right.
shared the names with you.
Okay, thank you. Okay. All right, here goes. Okay, everyone can see it?
Yes, sir.
Okay, I'm putting it on play. So
Right.
thank you very much, Santosh, and I'm delighted because to have Pradeep and Harsh here with me. I cherish many memories of being with them at many conferences across the country, and I'm so delighted to have them chair this meet. And thank you, Dr. Bansal, also for moderating this session. So I'm going to talk to you about just give me a second. So I'm going to talk to you about the Central India Eye and Medical Study, and of course, its implications for India, and also talk to you a little bit about the other studies that have been done, telling us more about the epidemiology of glaucoma. As is always the case, no study can be done alone, or in perhaps today's day and age, most major studies cannot even be done by an institute alone, actually. So you need to connect with people and collaborate, across institutes and across countries if you want to be able to do something that will make a difference. So this is the team, and I hope I haven't missed out anyone. And there were so many people that worked together with me on this. And thank also to Professor Jonas, who actually, took up this idea that I had in really, enabled this study to take place and gave a tremendous amount of scientific input for this study. I would like to, so I'm just going to, I would like to introduce the importance of epidemiology with the example of COVID. And COVID is the largest epidemiological study worldwide because the entire global population of 7.9 billion was involved. Every country wanted to know what is happening to every single person living in that country, actually. The importance of epidemiology in saving lives is being demonstrated vividly day by day, and it has rekindled the branch of epidemiology like no other event in recent history. Never before have predictions of what is to come been so helpful in shaping the future of the world as they have been with COVID, actually. I'm not able to shift the slide, actually. Is there anything that I'm not able to do?
Press the, sometimes you just have to press the.
That's right. I press the mouse and it's there, actually. So it was the purpose of the Central India Eye and Medical Study, which was a cross-sectional population-based study to determine normative data with special reference to glaucoma and to determine the prevalence of glaucoma and its association, besides a host of other ocular and systemic parameters, because we're just restricting ourselves to glaucoma for this meet. So this was a population-based study in rural central India. There were 8 villages in the rural region of central Maharashtra at a distance of about 40 kilometers from Nagpur. And the inclusion criteria was age 30 plus years. And we had a total of 4,711 study participants with a response rate of 80%. And the mean age of those who participated was 49.5 years. And this is, you can see here, let me just use the laser pointer. So we are somewhere here, actually. Nagpur, this is Nagpur, and this is Nagpur, and we worked very close here, actually. Very, very close. We worked to Nagpur to do this study. Next. So all patients underwent an eye examination, including visual acuity, automated refractometry, subjective refraction, slit lamp biomicroscopy, applanation tonometry, gonioscopy, biometry, fundus evaluation, Heidelberg retina tomography, color photography, and the systemic evaluation included height, weight, pulse, blood pressure, and almost all systemic parameters, including complete blood count, urea, creatinine, blood sugar, cholesterol, glycosylated hemoglobin. They were all done, actually. So let me go to what we found. So let's start with the optic disc, and we determined the optic disc. The optic disc size was found to be 2.25 millimeters square with a range of 1.12 to 4.61 millimeters square. So anything less than 1.23 millimeters square or less were classified as small discs, and those that had optic disc area of more than 3.27 millimeters as large discs. This tells us the size of the optic disc in a community. And also we found through the study that it was influenced by axial length. The clinical importance of optic disc is known from the fact that large discs have large cups and may be suspected to have glaucoma, and small discs have small cups and may be missed to have glaucoma. So in the Beijing eye study, the optic disc size was measured to be 2.65 millimeters square. In the Rotterdam eye study in the Netherlands, it was 2.42 millimeters square. And you can see that the size of the disc differs, but also because different techniques were used for measurement. But these are the data that are available from different parts of the world, actually. I'd just like to show you how the large optic disc has a clinical significance. So we studied 149 eyes with primary open angle glaucoma, and we were able to demonstrate that subjects with larger discs had less visual field loss and subjects with smaller discs had greater visual field loss. But this was a clinic-based study. And so we may think that perhaps because larger discs gave rise to a suspicion of glaucoma earlier, and perhaps therefore they were diagnosed earlier. However, there is no specific evidence that simply having large discs may cause glaucoma, even though African Americans have large discs and have a higher prevalence of glaucoma, actually. But I do think that it puts a little bit into perspective the importance of knowing whether the disc you have in front of it is U is large or it is small. Now, this is another patient that had small disc. If you take a look at this disc, you can see that's a small disc. There's no cup visible actually. When you look here compared to the inferior retinal nerve fibula, you get a sense that you're not able to see the retinal nerve fibula sufficiently. And when you go across to the OCT, you'll find that there is a superior retinal nerve fibula loss, and you can see the flattening of the superior hump actually. And this is the left eye, and you can see that it's still all right. And this was a patient that had very small discs with significant retinal nerve fibula loss that we may not have been able to recognize. However, he came with steroid-induced glaucoma, and I just wanted to show you what a small disc, with glaucoma can look like. Intraocular pressure is an important hallmark of clinical assessment, and several decisions are made taking the measurements into consideration. In our study, the mean IOP was found to be 13.6 millimeters of mercury with a range of 2 to 56 millimeters of mercury. This gives us an indication of what may be considered normal and abnormal according to current understanding of intraocular pressure. So through these intraocular pressure measurements, we may define associations with optic disc morphometric parameters to tell us how sensitive they may be to intraocular pressure. As an example, the neuroretinal rim shows decay as the intraocular pressure increases, even within the normal range. And this has significant clinical implications, actually. And this is a histogram that shows you the distribution of intraocular pressure as measured by the Goldman applanation tonometry in the Central India Eye and Medical Study. So this is a multivariate analysis, and I'm just, pointing out some arrows. For example, body mass index was related to intraocular pressure. The level of education was surprisingly related to intraocular pressure, and corneal refractive power was related to intraocular pressure, because when the corneal refractive power is more, the curvature would be more, and therefore more pressure may be required to applanate the cornea actually. So these are some correlations that come out, and I think over a period of time, they'll form the matrix that we need to create for every important systemic reading that we have to tell us what is it that actually influences these parameters actually. So in the Chennai glaucoma study, the mean intraocular pressure was 14.29, and in the rural population, it was 16.17 in the urban population. So the urban population, the Chennai glaucoma study had somewhat elevated intraocular pressure. We don't have a way of actually explaining the difference that you have within Southern India and Central India. For example, ours was a rural population that had an intraocular pressure of 13.4. Their rural population had an intraocular pressure of 14.29. And we didn't have an urban arm actually, and that's why we're not able to compare that. In the Blue Mountains Eye study, the intraocular pressure was 16 millimeters of mercury. But of course, the mean age there was much higher at 65 years. And we know that the intraocular pressure tends to increase with increasing age. The central corneal thickness in our study was found to be 514 microns. And the applanation tonometer, as you know, was built to measure an intraocular pressure for a central corneal thickness of 520 microns. And to our surprise, the central corneal thickness in Caucasians is about 540 microns. So I think that the Goldman applanation tonometer was classically built for Indian eyes, actually. This is a histogram that you see of the distribution of the central corneal thickness in our study. Now, this is just to take a bird's eye view of what's the corneal thickness like in different studies. In Chennai glaucoma study, it was 520 microns. In the Rotterdam study, it was 537, that's Caucasian. In the Beijing eye study, it was 556. In the Singapore Malaya eye study, it was 541. So you can see here that the Central India Eye and Medical Study had CCT of just 514 microns. Perhaps there is some importance to that in terms of how we would treat patients here with a certain intraocular pressure. So while a normal range of CCT indicates that the intraocular pressure measurement is fairly accurate, the difficulty comes when the CCT is not within the normal range. We don't know which formula to follow because based on regression formulas from large epidemiological studies, no standards could be set because the results of regression differed in different studies. Therefore, as a guideline at Nagpur, what do? we consider low CCT to be roughly 40 microns less than the mean CCT that we found in the study, and increased CCT to be roughly about 40 microns more. It is just a clinical impression that when this change occurs, the difference in intraocular pressure measurement may reach or transcend 4 millimeters of mercury. This is an anecdotal figure, and this is largely drawn also from measurements of intraocular pressure in the pediatric age group. You have babies that you want to rule out glaucoma, and you check their CCT, and they have, very thick CCTs often. And that's how we've sort of considered this relationship. So what was the methodology for glaucoma in the CIEMS? We studied the disc, and that's including the cup, the diameters. We drew all of them, including the neuroretinal rim. And then glaucoma was defined by a glaucomatous appearance of the optic disc. The optic nerve head was glaucomatous based on the non-conformity to the isn't rule, comparative thinning of the superior or inferior rim to the temporal rim, or an abnormally large cup in a small disc, actually. So this was a very clinical way of assessing the optic disc and the retinal nerve fiber layer. So the optic disc photographs were available for 97% of subjects. We had both 20 degrees and we had 50-degree photographs from the Zeiss fundus camera. The mean age, as you know, was about 48.5 years. The mean refractive error was 0.06. And that's very helpful, because if the refractive error was more, then that's not excellent, because then you have to divide the subjects, because when you have a greater refractive error, that means you have included patients with a longer axial length, and therefore there would be more myopes, and then you would have to segregate what's happening. And the mean axial length, this is very important, was 22.64 millimeters of mercury, because I think the life of glaucoma specialists, and also to a large extent of many retina specialists, revolves around the axial length. So using ophthalmoscopic criteria for definition of glaucomatous optic neuropathy, glaucoma was detected in 193 eyes, that's 2.1%, 122 subjects. And the open angle group had 108 subjects and 172 eyes. Primary angle closure glaucoma group had 14 subjects in 21 eyes. And the ratio of open angle glaucoma to angle closure glaucoma was, for our subjects, 7.7:1. And I think that's probably very good news to have a ratio like this. It makes life much easier for the glaucoma specialists, for the community, actually. And probably it's also indirectly saving sight. The prevalence increased significantly with age. This is something that all of us need to remember, that age is the most significant dynamic in the development of primary open angle glaucoma, and also to a large extent associated with other parameters in the development of primary angle closure glaucoma. So for the study population of 40 plus years, the prevalence was 3.45%. For 50 plus years, it was 5.11%. And for those above the age of 60 years, it was 7.5%. So what is the implication? The implication is simply this, that with better technology, I think we're able to diagnose more glaucoma. So let's say for 60 plus years, if the prevalence was 10%, and I really do believe with modern technology, it would be reaching around that. So in a hall, if you have 100 people sitting, 60 years and above, that means that 10 of them would have glaucoma. And that's really too much, actually. So glaucoma is not something that we may just think that, that is something that we may not perhaps pay too much attention to, because many of us, those who are above 60 years in our country and elsewhere, are likely to end up with glaucoma, actually. So this is the age-specific prevalence in different age group. This is Andhra Pradesh eye disease study. This is the Chennai glaucoma study. This is the Arvind comprehensive eye study. And you can see that the prevalence increases, and it's really maximum. You can see the jump between 60 to 69 years to more than 70 years. And in the Chennai glaucoma study, it's so tremendous, from 4% to 9.14%. And I think there lies a lesson that maybe you're going to see patients over the age of 40 years, but as you get people who are above 50, above 60, and above 70, you need to spend more time, and you need to focus more on diagnosing glaucoma and associated conditions in these patients, actually. And this is a multivariate analysis. What did we find? What are the parameters that were associated? So age was associated, body mass index was associated negatively, intraocular pressure was associated, and we know that. We know that disc hemorrhage was associated, myopic retinopathy was associated, and axial length was associated. So I think these are things that we need to remember, that if you have a person who has a longer axial length, and I will come to it, please remember that he's at very high risk of developing glaucoma, and please have a good look at his optic disc, never mind the challenge. So the axial length in myopia shows a strong correlation to the development of glaucoma. The normal axial length in CIEMS was found to be 22.6 millimeters, and the range was 18.22 to 34.20. And you can see what happens to the optic disc. These are glaucomatous optic discs in patients who had a higher axial length. The photograph on the left side shows the axial length of 25.6, and the photograph on the right side shows an axial length of 26.00. But these are discs where it was very easy to diagnose that they had glaucoma. There are many myopic discs where it's very, very hard to diagnose if they have glaucoma. And this is a study that really struck me as being very exciting, where they found that in subjects that had an axial length of less than 26.5 millimeter, the prevalence was 12.2 in those who were myopic. And when the axial length increased, it increased to 28.5, and over 28 millimeters, the prevalence increased to 32.6. And over 30 millimeters of axial length, it increased to 42.1%. So I think that, myopes are a challenge for glaucoma and both for retina. And we need to really pay attention to the myopes, actually. This was a study that we did at our hospital, and we said, let's take a mean of 22.6 and plus standard deviation. And we created a group of those with POAG with less than 23.5 millimeter, considering this axial length to be sort of the normal axial length. And we had 105 subjects with POAG in that, 105 eyes actually. And in the group 2, where the axial length was more than 23.5 and less than 24.4, there were 148 subjects. And in the group with axial length more than 24.4, we had about 71 subjects actually. So I just want to show you that the number of glaucoma patients that had an axial length more than mean plus 1 standard deviation was much, much higher than those that fell in the normal range. So what I'm trying to tell you is that if you get someone with an axial length that is just 1 millimeter more than the mean that is found in your area, please consider that person to be at very high risk for glaucoma. And that is a subject you need to really follow up for the future, actually. The relationship of myopia to glaucoma is very important based on evidence from existing literature and also from our own study. And therefore, we consider that doing axial length measurement is as important, perhaps, and sometimes even more important than doing the central corneal thickness. And we do that for all the patients, actually. Increased axial length is associated with change in the shape of the optic disc, making it more difficult to assess for glaucoma. So these are all eyes. This is a glaucomatous eye. This is a glaucomatous eye. And this is also possibly a glaucomatous eye, actually. So let's go to primary angle closure glaucoma. Actually, you can see the different studies and you can see the prevalence. In adults, the prevalence of PACG was just 0.5%. In the Arvind Comprehensive Eye Study, in the Chennai Glaucoma Study, it was 0.88%. In the Andhra Pradesh study, 0.94%. And we're really fortunate. We had a prevalence of 0.30%, but this was a study where there were patients who were aged 30 years and above, and that could possibly be responsible for reducing the prevalence. And you can see that as you go to the south, Beijing Eye Study from China had a prevalence of 1.02, and all 3 Singapore studies, the Tanjong Pagar Eye Study, that was, I think, on the Chinese, had the highest prevalence of 1.14, and the Singapore Indian Eye Study, that is Indians living in Singapore, was 0.18. So in general, it comes through that Indians perhaps may have a lower prevalence of primary angle closure glaucoma. The prevalence of angle closure glaucoma was significantly correlated with older age, higher intraocular pressure, higher prevalence of disc hemorrhages, more hyperopic refractive error, shallower anterior chamber, shorter axial length, higher vertical CD ratio, and greater lens thickness actually. So these are the things that you look at. And, while in the clinic, we pay more attention to the greater lens thickness. To us, that is a very important parameter. But really, all of these come together. It's not as if you find greater lens thickness and don't find a more hyperopic refractive error, or don't find a shallow anterior chamber. So all these things are related with each other, and perhaps one of them may be much more important than the others. But really, it's a constellation of things that you find in an eye with primary angle closure glaucoma. So this is the ratios. In our study, it was 7.7:1. In the Chennai glaucoma study, 4:1. Arvind comprehensive study, 3.4:1. In the Beijing eye study, 2.6:1. And in the Singapore Malay eye study, it was 25:1. And what is the importance? Why are we talking about ratios? We're talking about ratios because PACG patients are likely to go blind sooner. There is an inflection point at which the eye pursues blindness once there is angle closure actually. PACG eyes are less sensitive to lower levels of elevation of IOP, simply because PACG is only associated largely with elevated intraocular pressure. And therefore, it has got much less to do with vascular insufficiency as being an important cause of optic disc damage. So I don't see patients that have got, let's say, primary angle closure, who's a primary angle closure suspect with intraocular pressure of 17, 18, 19, developing optic disc damage actually. So there are many things, and also from evidence from other parameters also, intraocular pressure is the primary important contributing factor to glaucomatous damage. The most important challenge to us is that we get many patients with PACG where one eye is almost blind or about to go blind, and the other eye is still normal. So the asymmetricity of PACG is tremendous in nature and is really extreme. So I'm just showing you these photographs to tell you that when you have a PACG patient, it's the asymmetry that's really a challenge. Sometimes it doesn't work out too well because the patient has come too late. And therefore, this challenge of continuously doing gonioscopy, examining the peripheral anterior chamber depth, trying to get patients where there is a family history of PACD. This is the second patient, again, asymmetric presentation with one eye, more than 90% cupping. And this is another patient. You can see this photograph on the right side, that is of the left eye. And, the patient is also significantly, has significant glaucoma damage. I want to introduce you also to Translamina Cribrosa pressure differential. The Translamina Cribrosa pressure differential has been defined as the difference between IOP minus the cerebrospinal fluid pressure. It has been further considered that since the lamina cribrosa is considered to be the primary site of damage to the nerve fibers, the pressure zones around this may be more important as a causative factor in the evolving glaucomatous damage. It's also possible to consider that translamina cribrosa pressure differential may be more important than intraocular pressure. So I just want to show you, this is the photograph of the eye, and this is where the pressure falls on the optic disc. And this is the red arrow with the pressure here. And there's also pressure here. And this is the fluid here. This is the subarachnoid space, and this is the CSF fluid. This is the lamina cribrosa. So in a disc like this, where there is no cupping, the pressure is transmitted through here, translamina cribrosa pressure differential. But in a myopic patient or in a patient where there's already a large cup, this arrow would reach right into the cup, right to the lamina cribrosa, and the pressure differential would start from here to this area actually. And myopic eyes have got very large subarachnoid spaces because of the development of gamma zone, where the Brooks membrane gets pulled away from the margin of the optic disc. So we found in our study that the glaucoma group had a mean intraocular pressure of 17.2 millimeters of mercury, non-glaucomatous group 13.7 actually. The cerebrospinal fluid pressure was 7.6 millimeters of mercury in the glaucoma group, and it was 10 millimeters of mercury in the non-glaucomatous group. And the translamina cribrosa pressure differential was much higher in the glaucoma group compared to the non-glaucomatous group. We did not do cerebrospinal fluid taps in all our patients. This has come through a formula that was created by Professor Jonas, and we applied it to our study, and it was also applied to the Beijing Eye study. And we got this relationship, and that was really very exciting. If you could, reflect on CSF pressure and translamina Cribrosa pressure in an epidemiological study with nearly 5,000 subjects, I think that was tremendous, actually. So glaucoma prevalence in rural central India was determined, and glaucoma was associated with older age, lower body mass index, lower blood concentration of hemoglobin, higher intraocular pressure, optic disc hemorrhage, higher prevalence of myopic retinopathy, longer axial length. And the ratio of open angle glaucoma to angle closure glaucoma was 7.7:1, actually. In today's world, is it enough to do a study like this? And the likely answer is no, actually. As we move towards personalized medicine and begin to recognize that each human is or may be a little different from the next, we need to evolve to consider normal in the context of that individual, but not necessarily try to fit that individual in the normative data from an epidemiological study. And the mean and the average and the range, that is sufficient indication to us that the mean isn't something that can be applied to everyone that comes to you in your clinic. And the whole purpose of doing an epidemiological study is how can you look at that particular person from a perspective of the entire community. So I think both have to merge. The epidemiological study and the personal data have to merge together, actually. So how would we do an epidemiological study for glaucoma, and what would we look for if we had an opportunity today, actually? So we would like to do OCT for all subjects in the study. We'd like to do the retinal nerve fiber layer scans. We'd like to do enhanced depth scans for the optic disc. We'd like to identify the peripapillary tissues that will end up likely playing a very important role in the development of glaucoma. Because the choroidal circulation passes through this area to supply the optic nerve. And then we need to understand the macular morphology and how is the macular morphology, related to the retinal nerve fiber layer and central, because the ganglion cells, they clothe the fovea, and those are the axons that form the retinal nerve fiber layer. So often we're looking at the retinal nerve fiber layer, but not sufficiently looking at the ganglion cells that we need to. And of course, choroidal thickness would become also important, because it supplies nutrition to the outer layers, actually. We need to count the photoreceptors, the thickness of each individual layer. This is a pure ganglion cell layer map, and that's tremendous sometimes to take a look at it. The optic disc circulation, vascular patterns using the OCT angio. So this is what an epidemiological study of today will look like, because we need granular. Granular comes from the term that when you see several pieces of stone that have been crushed into very, very small pieces. So that's very granular compared to a big boulder, or compared to a boulder that's been broken into 5 pieces, actually. So just merely, checking the vision or saying this patient, could have AMD, or, this patient has visual impairment, that's probably not going to be enough if we need to go to the next level of beginning to understand and create an epidemiological data for personalized medicine, actually. So the development of a disease may be associated with risk factor. What are these risk factors? For example, do we know that clean water and sanitation have any role to play in eye health? Why did we find a relationship of education? We found a relationship of height with good vision, actually. So we need to study the epidemiology of accessibility of quality of care, affordability, compliance, attitudes, behavioral patterns, social support, profession, economic status, geography, medical education, that could significantly affect the diagnosis and management. So this is all part of the next generational epidemiology that we need to look at, actually. On the basis of several population-based studies in India, it was calculated that there were 11.2 million people affected over the age of 40 years, actually. They had glaucoma. POAG was 6.48 and PACG at 2.58 million. There were many, many millions with primary angle closure disease. So on the basis of Central India Eye and Medical Study, if we take a population of 1.21 billion, I understand the population has increased a little bit, but let's stick to this. With the prevalence of 3.45% above the age of 40 plus years, we would have 11.27 million affected. And at the age of 50 plus years, we would have 9.79 million. And over the age of 60 plus years, we would have 7.78 million affected. So that's what we are looking at. That's the data. That's the number of people that have got glaucoma. And why are we not doing well with glaucoma? We're not doing well with glaucoma because there is a very strong correlation of the socio-demographic index, which includes the amount of money, the per capita income, it includes fertility, it includes the level of education. We're not doing well. We're actually low to low middle social demographic index. And let's say we have a GDP of 2.6 million versus the UK at 2.67 million. But the per capita income in purchasing power parity is $5,350, whereas in the UK it's $39,000 and in the US it's $55,000 actually. So that's the problem. Our health expenditure is 1.4%. So of course you can do miracles with small amounts of money, like for example doing charity surgery, but you can't really do amazing things actually that need to be done to take ourselves, India, to the next level, as long as our economy doesn't increase, or as long as the health expenditure really reaches the level that it should reach actually. So never mind that we've come a long way, but we really need to go a long way. And the point that I'm trying to make it is that just like everything else, glaucoma, we're not going to make it with glaucoma unless and until the economy increases and the health expenditure increases actually. So not more than 10% have been diagnosed or are aware that they have glaucoma. 70% of the glaucoma is in the rural areas, almost all undiagnosed. 90% of glaucoma subjects are potentially under threat of visual impairment of blindness actually. And that's really tremendous for a country like us, where there are sufficient other problems that we face, to think that, that so many of us are under the threat of incurable blindness. And I will explain to you what that incurable blindness means and where India is headed after 2050, actually, as I show you some global maps, actually. So globally, glaucoma is the third most important cause of blindness, with roughly about 3 million being affected, actually. Then in high income regions, such as in Europe, including Australia and North America, glaucoma is the #1 cause of blindness. Please understand, it's the #1 cause of blindness actually. And then in South Asia, it's the #3 cause of blindness. And South Asia is basically India, Pakistan, Bangladesh, Bhutan, Nepal. So it's #3. And of course, we know that because cataract and uncorrected refractive error are the #1 and 2 causes actually. So what I'm trying to say is that after 2050 and reaching the end of this century, the population of India will be less than 1 billion. So our population is going to decrease after we cross 2050. And sometime between 2050 and the end of this century, you're going to see that glaucoma could become the #2 and then perhaps the #1 cause of blindness. So I think we need to do a lot. We need to create and monitor structured and sustained public eye health services, trained manpower, image algorithms, big data, personal eye care. We need to see something set in motion to see a reduction in the cases of undiagnosed, unaware, and untreated glaucoma, or I call it U cube. That's U for undiagnosed, U for unaware, and U for untreated. And to reach a level of diagnosis of 50%, it could take, if we are very fortunate, it could take 10 or 20 years if we were to work on a war footing to tackle glaucoma. Thank you very much for a patient listening, and I'm going to end my talk here.
Thank you, Vinay. I think that was really, really nicely done.
I'm just trying to show, isn't it? I can end this now.
Yeah, you can just stop sharing.
Yeah, I'm just, I'm trying to see whether stop sharing this thing is. I got it. There you are, actually. There we are. Okay, all right.
Yeah.
So Pradeep, were you all right with this long lecture? It was too much for me also. But
No, it was fantastic. Very interesting. I enjoyed
right.
thoroughly, and not only enjoyed, learned a lot. See, it is very, very difficult to do the population-based study. Right. You need lots of money, infrastructure, manpower, and time. And who has in India? So whosoever takes the lead, probably, they are doing a very good service to the science. And you did it in Central India. That's what fantastic, because all the other three major studies were from South India. So this is the only study from North India, and we are seeing some data coming from the East India as well. So now Harsh has to take up the North India.
Okay, I think this was wonderfully done, Vinay, and like Pradeep said, you have clarified so many things for us. And for the students, I think it is an important thing, because you have told which are the risk factors. And once you do a population study, that is the idea, that you get an idea of what is your major dealing with. And I think one thing it very clarifies from all the studies is that we had always been, many a times we were teaching our students that ACG and OAG are almost 1:1, which is not at all true. And but yes, then again we have to know how much is angle closure, because it is the one which can cause 3 times the blindness that of open angle glaucoma. And once you have clarified the risk factors for us, then students can, once they deal with these cases, they can look at it in that perspective. So Pradeep.
Yeah, that's beautifully done. As I said, that the most important point you brought out is that measuring the axial length. We do everything. We do the OCT, we do the perimetry, we do the CCT, and if we have a ORA, we do that. But we hardly give importance to measuring the axial length. And you brought out this point very significantly. And I think we should start doing the axial length henceforth for most of our glaucoma patients. But I just want to ask one question to you, that in the high myopia or extreme myopia, how do you diagnose glaucoma? Because it is very difficult to interpret the disc, perimetry, OCT, in the segmentation in the OCTs. All is very difficult.
It's such a great question, Pradeep, and I think everyone goes through a tough time in trying to figure out what's really happening in an eye. So for us, I think that there are two things. One, if you have a high myopia with elevated intraocular pressure, then you do get a glaucomatous cup actually. So it makes life a little bit easier. The second important thing is that, if you have a myopic eye where the intraocular pressure in the normal range, that is the real challenge actually. So, I'm talking, when you say high myopia, then I'm really talking of in the range of, 28 or 30 millimeters of axial length and above, with a completely distorted disc actually. So in these cases, the retinal nerve fiber layer, if you have a retinal nerve fiber layer that is significantly thinned out in one area compared to the other area, that is, there is asymmetricity of glaucoma in the same eye. Let us say that the inferior rim is significantly thinned out, then of course that also aids you. The third way of, the third hint that you can get is if you have the old manual perimeter actually, because they say that with the manual perimeter, because often the central vision may not be that good in high myopia and you get, myopic macular degeneration. So they say that if you use that, then that is another way of diagnosing some of these patients with glaucoma. The fourth difficulty that you will have is diagnosing also tilted discs that have glaucoma, because the inferior rim often is very, very it's almost absent in tilted discs actually. So these are the challenges that we face, and if you're not sure that a patient has glaucoma, then we are definitely it's a challenge actually. The difficulty with the retinal nerve fiber layer is that if you have a 3.4 millimeter circle that goes very close to the parapupillary atrophy, you'll be surprised that then you get thickened retinal nerve fiber layer because it's very close to the edge of the parapupillary atrophy. And the thickening of the retinal nerve fiber layer will not only come in the macular area, but partly in the superotemporal and partly in the inferotemporal area. So these are the challenges that one faces actually. In some patients that have got myopia, you will be very fortunate, because a lot of the myopia may be because of the high corneal refractive power. So the axial length may be just 25, but the person may be -8 myopic simply because the corneal refractive power is very high. And when that happens, then there is a very high chance that the disc the structure of the disc is not altered significantally. You may not get a parapupillary atrophy, and therefore your retinal nerve fibrillary readings or your normal visual fields that you do, they may still be of value to you.
Anyway, the GCC is important, the ganglion cell complex.
So, there is a challenge with the GCC. In the very high myopes, you may not be able to get the ganglion cell layer actually. But in many patients, we are able to get the ganglion cell layer. And this is all very preliminary because the data is yet to be analyzed. But there are many normal myopes that have got patchy areas of ganglion cell loss. By patchy, I mean less than 1 percentile thickness of ganglion cells actually. So the question is that if you take a myopic patient, what would be considered to be normal actually? Because the retina becomes a little thin, it becomes a little stretched, and therefore many of the layers also become a little bit thinned out actually. So I think we still have to analyze them. Unfortunately, we were not able to get the normative data from the instrument manufacturers. So we will probably end up using our own normative data to compare what is happening in the myopes. But that's the challenge. Patchy areas of ganglion cell loss showing less than 1 percentile values in the macular area, in eyes that are non-glaucomatous, and even in youngsters, young myopes. That's the challenge to the value of ganglion cell loss in using it for detection of glaucoma and myopia. I can't hear you, Harsh. I can't hear you.
Yeah. Okay.
Yeah.
So what I was saying that, let's say there is a little bit of confusion and the pressure is around 18, 19.
Yes.
And the problem is that whatever visual fields we get,
yes,
when they become a little worse, we are never sure whether it is because of the retinal degeneration in these cases, or
yes,
is it actually the cup which is becoming bigger, which is practically impossible to make out. So I would say that wherever there's really no harm in starting a medication for some.
yes. I think there's no harm in starting a medication. And likewise, if you take a color photograph and do the infrared photographs that come with almost all OCT machines. So you have the opportunity of following up on an increase in the size of the cup or decrease in the rim actually. So those are things that you can take a look at actually. There are also a particular kind of myopic disc that and I think others are also calling it myopic optic neuropathy. There is pallor of the disc actually, but it's not really glaucoma. So these are also discs that you need to separate out from those that you're thinking that have got glaucoma, because pallor of the optic disc that we call myopic optic neuropathy has got no relation with the intraocular pressure, and giving drops in these patients may not be necessary.
Okay, there are some questions here. What is the most cost-effective method of screening for normal tension glaucoma?
I think it's really looking at the optic disc actually. That's the simplest thing to do, that you dilate the pupils and you take a look at the optic disc. That's the cheapest thing that you can do, most cost effective. I want to tell you that, screening is a different, it's a different set of challenges altogether. But what is more important is that, in India, roughly about, and also in most parts of the world, about 50% of the patients that come to you that are diagnosed to have glaucoma for the first time will have normal intraocular pressures, and therefore they would be classified as normal pressure glaucoma actually. So you really don't need to go hunting out to specially screen. Screening means that you're going out to an organization or going out in the village to screen, and screening is very difficult. It requires, at a time when you have great technology and you can take a photograph, upload it, do image analysis. Till that time, screening on a large scale is not something that is going to work out actually.
Yeah, so I think you have to clarify for them that, for the students, because there are a number of other questions also related to that kind of a thing. So it is screening for glaucoma per se in a population for a study is good, but it is simply not possible because the detection rates are not cost effective at the level of our earning.
Yes. So I just want to also point out that this population-based study was not screening actually. Screening, somehow you have a sense that you need to see the patient quickly and you don't have your ophthalmic equipment with you. This was, all the patients were brought to the hospital and they were examined all through the day. I think they spend the entire day over there, and they, it's just like you do a complete eye examination for any of your private patients. That's how we examine them actually.
This is
Yeah, they are not the patients.
Sorry?
It's just a population.
I beg
they
your
are
pardon.
not the patients.
They're not patients actually. I beg your pardon.
Right. Pradeep always catches every spot.
Well, I don't want to say some of them turned out to be patients actually.
Yes.
This is data of which year? Data of which year? There is a question. The data of yours, Vinay, is of which year?
The study was done in 2006 to 2008 actually.
Okay. Pradeep, there's another question you can ask.
Yeah. So there is one more question for you.
Yes.
For people who have a family history of primary open-angle glaucoma, how often you recommend the screening for them?
So, this is a challenge because when you talk to people and say, get your family screened, it's not always that they get it screened. But I think at least once you tell them to get it screened, and if someone comes and he doesn't have glaucoma, then I'm not going to really push him to come every 6 months or every year or something like that. So just to give you an example, let's say there is a 40-year-old who's completely normal, and he has elder brother who's about 50 or 55 years old, who's just been detected to have glaucoma. So if this 50-year-old's optic disc is normal and other parameters are normal, I won't even submit him to intensive glaucoma workup if I think it's normal. And I think that I would not call him in less than 2 years time actually. Because they say that only roughly about 50%, there's a possibility that 50% of the family may have glaucoma and 50% may not actually. So I think you don't forget to rationalize your patient's visit to you, and I think that would be appropriate actually.
And just to add, you said that per decade of life, the prevalence or incidence of the glaucoma increases.
Yes.
Is that right? So I just want to ask you that, at the age of 70, the Chennai glaucoma study says that almost 10% of the patients may have glaucoma.
Yes.
Your study says that at the age of 60, 8% patient may have glaucoma.
Yes.
But some of them might be having a glaucoma from the age of 50 or 60.
Yes, of course.
But they might have detected at the age of 70.
Yes, that's correct.
And some might be developing the glaucoma at the age of 70.
That's
so there
correct.
There is a difference between these two. If somebody is developing glaucoma at the age of 70, it's a very early glaucoma, then it's very unlikely that the patient will go blind. So we should not be that aggressive for treatment for that particular
Yes.
patient.
So there are two ways of looking at that. That's fantastic what you just said. There are two ways of looking at it. One is that there is just a clinical sense that if you're unlucky to develop glaucoma at the age of 70, then because of not only because of the intraocular pressure, because of the other parameters, there's a possibility that you may progress a little bit earlier compared to if you develop glaucoma at the age of 60 so let's say if you had a normal pressure glaucoma of 17 or 18 millimeters of mercury, because of the vascular parameters that possibly come into play or whatever, there's a possibility that the rate of progress may be higher. But I don't have, this is all anecdotal. I don't have hard literature to quote on this actually. But I do agree with you that if you have a patient at 70 and you have glaucoma, you don't need to be aggressive. That is completely accurate actually, that you would follow up the patient and tailor your treatment as required.
Another point I just want to highlight is that when we say family history of glaucoma, what I realized is that some of the people have no clue what that family history means. So I now have started asking them to bring the fields of that person.
Yes.
But many of them are just ocular hypertensives. So you don't have to be that panicky in that situation, whereas a person who's actually lost vision in that eye because of glaucoma in the family. So I think the students must understand that please, when you ask them a family history and he says, yes, family mein hai, half the time they're not even sure whether it is glaucoma. So let them WhatsApp you the papers of the person having glaucoma.
I think that's really excellent to, not necessarily call the patients, but if they've already had an exam, just to, get them to send the details to you, and you can just, take a look yourself, and, so that's fine, actually. That's great.
There was one more question. I think that it will be difficult to answer this question. What population of rural India gets screened annually for glaucoma?
I mean,
it's very difficult.
Really, it's, I mentioned in one of the slides to that 70%, possibly 70% of the glaucoma resides in this thing. And I also said that possibly almost 99% of them are undiagnosed, actually. So that tells you that, screening in really rural communities, in the village communities, is very poor, actually, except it may have improved in some patches where you set up small clinics, vision centers. Those are places where screening for glaucoma must have begun to show a difference to the community, actually.
Yeah, I think that, by looking at these population-based studies, and I think government should make the policy that at least at the district level, if not at the block level or taluka level, they should train one ophthalmologist to detect the glaucoma, and they should provide the infrastructure like 90-degree lens, slit lamp, and maybe perimeter, so that at least the patients can be diagnosed, are suspected to have glaucoma, and can be referred to the higher center.
Yes. I completely support you, Pradeep, on this, and I'm sure Harsh agrees. And there were several meetings, etc. But unfortunately, I don't think that glaucoma is still considered seriously, actually. So there we are.
And maybe at the block level or taluka level, the primary health worker can be trained for the Von Harrick's or the flashlight test.
Yes, that would be excellent. Really, really excellent, actually.
Because if he says that 99% of the rural population is undetected, it's very alarming.
Yes.
Okay, I think that was wonderfully done, Vinay, and I am so grateful to you that you could spare your time for our session. And our students, I think, must have gained a lot, as I did and Pradeep did. So thank you very much.
Thank you.
And have a good time. Good night. Keep safe.
Thank you. So it was very nice to see you, Pradeep and Harsh, once again. And I'm glad that you chaired this session. And thank you very, very much.
We're lucky to be here.
Thank you. We are lucky to have you here. Thank you. Bye. Good night.
Bye-bye.
Thank you so much, sir. Good night, sir.
Good night. Bye-bye.